and welcome back. So this video has taken me a bit longer than I wanted it to, but that's because life's been pretty hectic over here, so I apologize. But finally I'm on here and able to finish this video up for you guys. So for today's video, I'm going to be talking all about women's health and then topics, of course, that you'll expect to see on your state boards exam. I'll discuss things like birth control, AUB, amenorrhea, dysmenorrhea, PCOS, cervical cancer, breast cancer, and osteoporosis. So lots to go over. At the end of the video, as always, I did include a dump sheet to help supplement your studies. Please don't forget to leave me any questions that you might have and subscribe to this channel if you have found it helpful in any of your studying. And on to women's health. Alright, so first up, I am going to be talking about birth control. Quick caveat, I did do another video all about pregnancy and STDs where I did discuss birth control. Some of this might be a little bit of a reiteration from what I had talked about in that video in regards to the birth control, that is. So you can skip over this, but you know, it is really important that you have a good grasp on it for your boards. It does come up, so I don't think it does any harm to hear some of this again. It is a very important topic. So combination hormonal contraceptives, we have levonorgestrel, norethindrone, and norgestimate. So those are our combination pills. They are our safer options. They have low androgen. They help with androgen symptoms, and they help prevent uterine malignancy. Levonorgestrel, this medication has less breakthrough bleeding compared to the norethindrone, which has an increased rate of breakthrough bleeding. And then also I wrote breath, but it meant breakthrough bleeding. Another couple options for the combination hormonal contraceptives includes both the patch and the ring. So the combination includes estrogen and progestin, and it helps to understand what each component does. So the estrogen, this typically helps with symptoms of the menses and helps with cycle control. If the patient experiences quote unquote normal bleeding or light bleeding, and bleeding is an issue for them, then we want to prescribe a lower estrogen, and that is about 20 to 25 micrograms of estrogen. If the patient is complaining of very heavy bleeding, if it's impacting their daily life, higher estrogen is then indicated, and that's between 30 and 35 micrograms. Progestin, this is the component that provides that contraceptive effect. There are the long-acting reversible contraceptives. The acronym is LARC, and that's the copper IUD or Paragard. This medication, this IUD, there's no changes to the woman's menses, but it can protect against pregnancy for up to 10 to 12 years. And then the levonorgestrel IUD, that's the Mirena or the Kyleena, and this IUD actually does decrease the amount of bleeding that the patient will experience. Before placing an IUD, it's really important that we confirm that the patient has no infection. If an infection is present, then we need to wait 4 to 6 weeks after treatment before inserting the IUD. And good to know is that LARCs, they can be safely used for nulliparous women, which means that women that have not had babies or not been pregnant, these long-acting reversible contraceptives are perfectly safe options for these patients. Contraindications to the hormonal or the combination hormonal contraceptives, really important to have a good understanding of what these are. There's quite a few of them, but really it comes down to if they have an increased risk of having some kind of clot, that is going to be a huge no-no for the combination drugs. But here is a list of those contraindications. So 35 years and older and smoking 15 or more cigarettes a day is an absolute contraindication. If they're less than 35 years and smoking, that's still a relative contraindication, and you'll do that case by case. But 35 and older, smoking 15 or more cigarettes a day, absolute contraindication to the combined oral contraceptives or hormonal contraceptives. 2+ risk factors for cardiovascular disease, so that's obesity, diabetes, hypertension. 2 or more risk factors for this, that's a contraindication. Uncontrolled hypertension, history of venous thrombosis, and not currently on anticoagulation, or women with an acute embolism, history of clotting disorder, heart disease, history of stroke, breast cancer, cirrhosis, liver cancer, or impaired liver function. For example, hepatitis C infection is a contraindication to the combined hormonal contraceptives. Migraine with aura, breastfeeding, and pregnancy all are other contraindications. So these patients, they will require a progestin-only contraceptive. And I did list those options for you here. So that's the Nexplanon, the Depo, the levonorgestrel IUD, which is the Mirena, the Kyleena. These are all progestin-only contraceptives and are safe choices for these patients, or safer choices for these patients, I should say. The Depo, it's important to know that this is associated with a decrease in bone mineral density. So we want to be cautious with our patients that might be at a greater risk of osteoporosis and avoid giving them the Depo. Also, the Depo, if the woman knows that she's going to be wanting to try for pregnancy soon, this contraceptive has a delay in return of fertility. It actually takes women up to sometimes 12 months after stopping the Depo for them to regain their cycle and fertility. So it's not an option for those, not a good option, I should say, for those patients that want to be pregnant or try for pregnancy in the near future. Okay, so abnormal uterine bleeding, or also known as AUB. This is an abnormal amount, duration, or frequency of bleeding, and it typically occurs from either structural abnormalities within the uterus, or it can occur from non-structural abnormalities outside of the uterus. So there's a really helpful acronym that's been already developed called the PALM-COIN acronym. The PALM portion relates to the structural abnormalities, and the COIN relates to the non-structural abnormalities. P is for polyps. Those can cause AUB. A is for adenomyosis. This is when endometrial tissue grows outside of the uterus. This can absolutely cause AUB because this tissue continues to grow and shed just like normal endometrial tissue. The leiomyomas, this is also known as fibroids. Those we know can cause AUB. Malignancy, this is obviously a big concern. Women that are postmenopausal, meaning that they've gone 12 months, at least 12 months or more without having a cycle, and then they experience bleeding, this is a big red flag. Up to 9% of these women actually present and have cancer. So with these patients, we want to refer them to OB to rule out any kind of malignancy. Coagulopathy disorders. Examples include von Willebrand's disease or factor V Leiden. Ovulatory dysfunction, this is obviously non-structural and it relates to the hypothalamic pituitary ovarian axis. There's endometrial dysfunction. There's iatrogenic causes, and this is either from medical devices or medications that cause a woman to experience abnormal uterine bleeding. There's lots of medications, for example, estrogen, progestin, IUDs, anticoagulants, even thyroid meds can contribute to AUB. And then the last being not otherwise classified. And I am going to make a video that I had made already when I was in school, all related and dedicated to AUB. It was something I used to study when I was doing my OB rotation. It's private on my YouTube. I'm going to open it up, so if you want to delve into it further, and I went very into detail about AUB, and I'll just direct you there if you want to know more than this. But this really covers the basics. Obviously, treatment is going to be tailored to what is causing the bleeding. So first we have to figure that out, and then treatment comes after that. Amenorrhea is divided into two categories, primary and secondary amenorrhea. So primary amenorrhea, this is the absence of a period or menses by the age of 15 years old. An example of this is Turner syndrome, which may cause primary amenorrhea. Secondary amenorrhea is the absence of menses for at least 6 months in a patient who previously did have periods or a menstrual cycle. Examples for secondary amenorrhea include pregnancy, which is the most common cause of secondary amenorrhea, also hypothyroidism, obesity, menopause, stress, anorexia, PCOS. So as you can see, the differential for causes for secondary amenorrhea, there's quite a list. Caveat here that's important to know is that some experts actually say that secondary amenorrhea is defined as only 3 months of absent menses in patients that had previous regular cycles. So if the woman typically had regular cycles and then went 3 months without a cycle, then we would still classify that as our secondary amenorrhea, as opposed to women that have irregular cycles, then a total of 6 months without a cycle would then be classified as secondary amenorrhea. Okay, so PCOS, or polycystic ovarian syndrome, this can be diagnosed using something referred to as the Rotterdam criteria. For diagnosis, 2 of the 3 must be present. The 3 being oligomenorrhea or irregular periods, hyperandrogenism, and polycystic ovaries are identified on an ultrasound. So symptoms of hyperandrogenism include acne, hirsutism, male pattern balding, and then of course an elevated serum androgen level. Also, these patients, they have frequently are associated with risk factors for cardiovascular disease, including obesity, glucose intolerance, dyslipidemia, OSA. And then also important to know that there are a lot of complications that come along with PCOS, including infertility, endometrial cancer, and then even mental health complications. So there are a lot of labs first to rule out any other causes for the oligomenorrhea. That includes the HCG, and that's of course to rule out pregnancy, TSH and FSH, that will help rule out thyroid dysfunction, hyperprolactinemia, and ovarian insufficiency. We can do the total testosterone. If the patient has a greater than 60, this indicates PCOS. And then if the patient has greater than 150, this actually indicates a tumor. So treatment for these patients depends on if they are trying to get pregnant or not. So if they're not trying to get pregnant, we're going to educate them, of course, coach them on healthy lifestyle, healthy eating habits, and combined oral contraceptives. These help to prevent endometrial hyperplasia due to the irregular shedding of the uterus lining, and it also helps to minimize those hyperandrogenic symptoms that they might be experiencing, like the hirsutism and the acne. Also, there's some adjunct therapies that can be used. Metformin may be used with these patients. Also, spironolactone, that can be used to decrease the hirsutism. If the patient does want to get pregnant or if they're trying to conceive, again, of course, we're still going to educate and coach them on a healthy lifestyle, but really important that we refer them as soon as possible to reproductive endocrinology because they can have so many complications, like I said, with fertility. Also important to know for these patients with PCOS, generally they are educated similarly to a patient with a patient who is diabetic on the dietary needs. So for example, things like lean protein and healthy carbs are going to be the best option for these patients. Patients with PCOS, they are at a greater risk for endometrial cancer, infertility, diabetes, heart disease, obesity, lots of complications like I think I mentioned already, but really important. But another important point here is that they're at a greater risk for endometrial cancer, not cervical cancer. Cervical cancer, that's a misunderstanding. Cervical cancer is related to long duration of HPV infection, typically the HPV 16 and the HPV 18, whereas PCOS, this puts the woman at greater risk for endometrial cancer. All right, so for menopause, remember that this means that the woman needs to go a total of 12 months without having a cycle. She could go 11 months without having a cycle and then have one on her 12th month, and she would have to start the countdown all over again. So it must be 12 months without having a cycle. There are some labs here that I listed for you that indicate a woman is perimenopausal. So that's an estradiol of 30 to 400. FSH greater than 30 or an AMH less than 0.5. This is a lab that shows us a woman's ovary reserves. So these women, they are at an increased risk of atrophic vaginitis, and the symptoms are going to be vaginal dryness, irritation, burning, and then dyspareunia, which is pain with sex. They may also, on exam, you may also see a loss of rugae and a pH of 5 or greater. So there are some treatment options. There's estrogen vaginal cream or tablets or rings. There's also an oral option known as osphinia. So there are some options to treat this for these women. Okay, so for dysmenorrhea, this is also divided into primary and secondary dysmenorrhea. For primary dysmenorrhea, the onset of symptoms typically begin shortly after the onset of the female having menstrual cycles. Very rarely do they complain of painful intercourse. Oftentimes, these symptoms do improve with pregnancy, and oftentimes these patients are responsive to the treatment options, including NSAIDs and the contraceptives. For secondary dysmenorrhea, The onset of symptoms generally don't occur till later, so mid-20s and older, and oftentimes the severity of symptoms increases. Also, these women will frequently complain of painful intercourse, and there might be other things also going on like endometriosis, pelvic inflammatory disease. These patients, they don't necessarily respond to the treatment options. They may, but it's variable. They may not find relief with the NSAIDs or the oral contraceptives like the primary dysmenorrhea patients do. So, for these reasons, secondary dysmenorrhea should be referred and managed to OB-GYN. For treatment for primary dysmenorrhea, this can be managed in primary care. First line is style modifications, educating the patient to increase their exercise and mobility. Obviously not when the patient is symptomatic, but as a general rule, also applying heat can be helpful. Second line is going to be the use of NSAIDs. First, generally, you want to recommend that the patient takes the NSAIDs on day 1 and 2 of their cycle. If this is not giving the patient total relief, then you can advise to trial the NSAIDs 1 to 2 days before the cycle begins and see if that helps the woman with her symptoms. If she does not experience symptom relief from the NSAIDs, then you can try to do adjunct therapy with the combination hormonal birth control. If the patient isn't experiencing relief from any of these treatment options, then it's appropriate to refer them to OB-GYN because something else might be going on. All right, so on to cervical cancer and cervical cancer screening. So cervical cancer, this generally develops from very persistent HPV infection over many, many years, persistent. Typically, this infection clears over 8 to 12 months. However, there are some strains that are more problematic, that being HPV 16 and HPV 18, which if you remember from earlier, there is a vaccine that helps prevent cervical cancer, and that's the Gardasil vaccine. And we want to get these into our patients preferably before they are sexually active. So ideally, we would give this vaccine between 9 and 14 years of age, and they would get 2 doses 6 months apart from one another. However, if they are sexually active, which Lord knows they start younger and younger, then they get 3 doses of the Gardasil vaccine. 15 to 26 years, they get 3 doses as well, and so do patients who are immunocompromised. 9 to 26 years, they also get 3 doses. After 26 years, it's not recommended for them to get the Gardasil vaccine as of now. Pap smear. So this begins at 21 years of age, and then every 3 years it's repeated. There's a couple exceptions there. If the result shows ascus or atypical squamous cells of undetermined significance. There it is. So if the results show these atypical cells in patients that are older than 30 years old, then they should be referred for a colposcopy. If they get these results and they're less than 30 years old, then they can just have their pap smear repeated in the following 12 months. Unless the results come back that the lesions are high-grade lesions, in which case the patient should actually be referred for a colposcopy as well. And if they're older than 25 years and the results come back as high-grade lesions, then the literature recommends that they go for immediate excision of the lesions. All right, on to breast mass and breast cancer. So a malignant mass is generally solid, and it oftentimes occurs in the area where the breast tissue connects up into the axilla, often referred to as the tail of Spence. So what are we going to do if we palpate a mass, or if our patient palpates a mass? Where do we go as far as diagnostics? So it's really divided into 2 groups, either less than 30 years old or older than 30 years old. So for our patients that have breast mass and they're less than 30 years old, first line is going to be an ultrasound. This also pertains to the pregnant patient, as we know ultrasound is going to be the safest option for mom and baby. And then if we palpate a mass in our patients older than 30 years, first line is going to be mammography. An ultrasound may also be done, but it's key to know that older than 30 years, a mammogram is indicated. 3D mammography is preferred, especially for those women that have dense breasts, because it gets multiple views. So, risks for breast cancer. There are multiple risks that increase the likelihood of a patient developing breast cancer. For example, the risk increases with age, with obesity, dense breasts, the female gender, though we know males can get breast cancer as well, a family history of breast cancer, longer estrogen exposure. So, these are the patients that start their periods at a young age, less than 12 years. First pregnancy older than 30 years, or nulliparous, so never being pregnant, and moderate to high intake of alcohol. And then there are genetic mutations that make our patients more susceptible to developing breast cancer. For example, the BRCA1 and BRCA2 genetic mutations. So, breast cancer screening, the recommendations by the different organizations vary, and so it's not tested on because they can't come to an agreement. But I did include them here for your reference, just in case that you wanted to review those for practice. All right, so our last topic for this discussion is going to be osteoporosis. So, what are some risk factors for osteoporosis? For example, the elderly, a patient who has had history of fractures, Caucasian and Asian patients, long-term use of steroids, cigarette smoking, excess alcohol, low body weight are all examples of risk factors for osteoporosis. So, the DEXA scan is a test that measures a patient's bone density, and it's recommended for women 65 and older unless they have risk factors, and then they can get this scan earlier. And for men, it's recommended for 70 and older, though if they have risk factors like the ones we discussed, also they can get this scan earlier as well. Also, those patients 50 and older that have a fracture should have a DEXA scan to check their bone density. So T-score is important to know for boards. So less than negative 2.5 is osteoporosis. However, a T-score of -1 to negative 2.5 is osteopenia. If the patient has a T-score within that range and has osteopenia plus risk factors, then we should treat them. Also, the FRAX calculator helps to determine whether or not who to treat. And the FRAX calculator, if you've ever looked it up, it's the fracture risk assessment tool. And it asks questions like age, weight, height, previous fracture, a parent history of a fractured hip, current smoking status, steroid use. So all these things that are risk factors, as we know, for osteoporosis. So first-line treatment for those patients is going to be the bisphosphonates, and this includes alendronate and risdronate. These are your first line, and this is what you really want to know for your boards exam. Also, we may need to supplement their calcium, though we prefer them to get it through their food. Greater than 50 years old, it's recommended that they get 1,200 milligrams daily, and then vitamin D as well is listed here, especially again for those patients 50 and older, and it's recommended that they get 800 to 1,000 units daily. All right, so this means that I have reached the end of my discussion. As always, here is the dump sheet to help supplement your studying, completely dedicated to women's health, and it covers all of the key points that you'll need to know for your exam, entry into practice as well. As always, please leave me any comments or questions that you may have down below, and please don't forget to subscribe to this channel if it's helped you in your studying, and to share it with anyone else that you think may benefit from it as well. I really appreciate your support, and as always, I wish you all the very best, and I will talk to you guys soon. Take care.